Now, look at what the Government Accountability Office found when they examined prescription rates for children in foster care. Here's GAO-12-201, December 2011. 5 states analyzed. Foster children prescribed psychotropic medications at 2.7 to 4.5 times the rate of non-foster children on the same Medicaid program, same payer. The GAO found hundreds of children on 5 or more psychotropic medications simultaneously. They found infants under 1 year old being prescribed psychotropic drugs. Infants. GAO-13-15, December 2012, ACF's own survey data. 18% of children in foster care on psychotropics versus 6.2% of non-foster medicated children. And children in group homes and residential treatment facilities medicated at 48% versus children in standard foster homes at 14%. Same federal agency, same data set, 3 times the rate, based solely on the placement type. GAO-14-651T, May 2014, the congressional testimony. The same findings delivered directly to Congress, and that T designation, that means testimony. This data was handed to elected officials in a formal hearing. They've already got it on the record. They already know. That was in 2014. Then a decade later, a 2023 study published in the Journal of Child and Adolescent Psychopharmacology analyzed nearly 400,000 children on Medicaid and found that children in foster care had 6.8 times higher odds of being dispensed a psychotropic medication than their non-foster peers. That's after controlling for age and actual mental health diagnoses. So the system itself is a variable, not the child's condition. The overall rate for foster children is now sitting at 35%, while the general Medicaid pediatric population runs around 8%. The same study found that foster children were significantly more likely to receive these medications with no documented mental health or developmental diagnosis at all, meaning that they're medicating the placement, not the pathology. The study's authors were Keefe, Cummings, Smith, Greenlee, and Van Horn out of Baylor College of Medicine and Texas Children's Hospital, published May 2023. Massachusetts, November 2024. Performance audit of the Department of Children and Families found children receiving dosages exceeding FDA maximums, lack of documented consent, failure to renew court orders for antipsychotics, and incomplete medical records across nearly all examined case files. The audit explicitly found that DCF couldn't even verify whether children were receiving therapy alongside their medications because the data systems weren't connected. So, you've got kids on 5 or more drug classes and nobody in the system can confirm whether anyone's also providing therapy. And that's not a documentation problem, that's a feature. Then, March 16, 2026, the HHS Office of Inspector General officially launched Project OEI 072600130 titled Treatment Planning and Medication Monitoring for Children in Foster Care Receiving Psychotropic Medications. And their own announcement stated that 10 years after their last review, high rates of psychotropic medication use among children in foster care remain concerning. 10 years, same problem. New project number. They handed this data to Congress in 2014 and opened a new investigation into the exact same problem in 2026. And the children in those beds right now are still generating difficulty of care supplements under Element 23, the same way they were in 2011. Because the financial incentive to diagnose was never touched by any of the testimony or the reports or the audits or the investigations. The incentive was never the target. The incentive has always been the point. The more institutional the placement, the higher the medication rate. Here's that chain. A child enters the system and the state documents a condition under Element 23. Now, that documentation will justify the difficulty of care supplement reimbursed by the feds. The diagnosis that generates the supplement also generates the prescription. The prescription rate in institutional placements runs at 48%. The diagnosis that medicates the child also makes the child more financially valuable to the placement. That chain isn't just a theory. It's 3 GAO reports in a 2023 peer-reviewed study, and a 2024 state audit, and a 2026 federal investigation, and a CFR citation 42 U.S.C. section 672A and 2, and 45 CFR section 1356.30. All public, all on the record. The GAO documented the correlation, but there's no federal oversight mechanism that currently cross-references difficulty of care payment claims against the specific diagnosis and prescriptions for the same child. AFCARS captures a condition flag, and Medicaid captures a prescription. But the two data sets are never officially cross-tabulated at the federal level. And that gap isn't an accident, that's a structural absence. No oversight body is required to connect them. No audits designed to look at both at once. And the structural absence in oversight systems that involve federal dollars are a congressional finding waiting to happen. An HHS OIG report confirmed the other side of that gap. Their finding was that treatment planning and medication monitoring were lacking for children in foster care receiving psychotropic medication. The system tracks the prescription for reimbursement purposes, but it doesn't track whether the prescription's working or whether it should have been written at all. And now, 12 years later, they've launched 0EI-07-26-00130 to check whether anything improved. And the answer, based on the Massachusetts audit and the 2023 Keith study, is that it didn't, that it got worse. The financial incentive to diagnose is documented, and the mechanism to verify that diagnosis still doesn't exist. That's not negligence, that's architecture. This is what a system looks like when it's working exactly as it was designed.